Thank you so much. Welcome all, and please keep filtering into our room. We have a very large number of people who signed up to join us for this conversation today, and we're thrilled. Welcome all. My name is Ann Greiner. I'm President and CEO of the Primary Care Collaborative, and for those who may not know the PCC, we are a membership organization, 70 organizations strong. Very diverse members, clinical organizations, health plans, consumer organizations, tech companies, pharmaceutical companies, employers, and the like. Very diverse, but what unites us is this commitment to strengthening primary care as the foundation of a high-performing health system. Primary care needs to be in all communities, and that's one of the motivations for our conversation today. How can this movement to value-based payment in all of its various forms make sure that it incents and supports safety net clinicians and patients who are themselves in the safety net? So it's a critical conversation that value-based models support the safety net. Let me just provide a couple of housekeeping remarks. I'll overview the topic of the webinar, make introductions, and then we'll have a conversation. So all of your lines are muted. We encourage questions. As you heard earlier, if you were on at the top of the hour, please put your questions in the question box. We've reserved the last 10 minutes of the webinar for Q&A. This webinar will be on our website within 48 hours. It's usually 24. So if any of your friends or colleagues missed it, you can certainly share a link and they can listen to the webinar after the fact. When we close out at 2, we're going to have a members only conversation with our esteemed speakers, and members who registered for that webinar should have gotten a link to join. If not, you can contact Edward Walrod to get that link. So our topic, we're joined by leaders from 3 very different primary care practice models, and they all share a commitment to the safety net and to providing primary care to underserved populations. Each of them are engaged in some kind of value-based payment arrangement and really run the gambit from Medicaid to duals to low-income Medicare beneficiaries. And they've got different kinds of ways they're doing this in partnership with plans, with ACOs, et cetera. So what we want to do with this webinar is figure out how we can, again, support the safety net in these models so that it benefits the beneficiaries, it benefits the clinicians who are participating, and the payers who also want to move toward value. After I introduce each of the panelists, they're going to explain to us how their organization structure, populations, and the geographies that they serve, how they differ. So let me start by introducing Dr. Matthews. Cameron Matthews is at CityBlock, and she's Chief Health Officer there. CityBlock was founded in 2017. From the very beginning, it was a transformative, it was on a transformative payment chassis, and it's a value-based provider for Medicaid, dually eligible, and low-income Medicare beneficiaries. At CityBlock, Dr. Matthews oversees all clinical operations, and that runs the gamut. Bricks and mortar, virtual, in-home, and community-based clinics. Dr. Matthews has long worked to serve underserved patients. She was staff physician at Cook County Jail and also served as Chief Medical Officer of Miles Square Health Center within the University of Illinois Hospital and Health Sciences System. And in that role, she oversaw 12 FQHCs. Prior to that, or actually after that, excuse me, she went to the VA and she was oversaw a national budget of $14 billion and helped in the transition to move toward community-based provider networks for veterans. She's really focused on transforming and integrating care to include medical, behavioral health, and social service lines within the VA. So I think we can look to the VA for tremendous innovation. She has a whole host of awards, and it's truly amazing. You can see her bio on our site, and she's a fellow at the National Academy of Medicine, on the board of directors of the National Quality Forum, et cetera. And there's more than I have time to read. So now over to you, Dr. Catherine Gergen Barnett. She's Vice Chair of Primary Care Innovation and Transformation in the Department of Family Medicine at Boston Medical Center. And she's also a clinical associate professor at BU School of Medicine and a fellow at the Institute for Health Systems Innovation and Policy. Dr. Gergen Barnett's been at BMC since 2009 after attending Yale University School of Medicine and working at NIH. Her primary clinical interests are behavioral health integration, preventive medicine, nutrition, mindfulness-based stress reduction, women's health, and group care. She's been voted Boston Magazine's best family medicine doctor and appears frequently in the news media. I think not only does Catherine publish in a lot of academic outlets, but she is a master at translating some of these complex ideas to the mainstream. And she's been on NPR and in the Boston Globe, et cetera. Finally, Dr. Stewart is from Concord, North Carolina. So we have geographic representation here. And he's a he's practiced general pediatrics for 40 years at Sand Hills Pediatrics. And this practice predates him. It's 56 years old, and it's an independent pediatric practice. Congratulations. For the past 10 years, Dr. Stewart has divided his time between Sand Hills Pediatrics and his role as medical director for Community Care of North Carolina. For those of you who may not know Community Care of North Carolina, who's a member of PCC, it has an allied statewide clinically integrated network, a CIN. And through the CIN, CCPN, which is the Physicians Network, supports 3,700 providers and over 900 practices. And they care for over 7,000 Medicaid beneficiaries. So as you can see, we're in for a real treat with the diversity of our panelists and the models that they're involved in. I'm going to call each of our physician subject matter experts by their first names, and I'm going to lead off with Dr. Matthews.
Thank you so much. Can you hear me? Yeah, exactly. Can you hear me? Everything okay? Good. All right. We can actually go ahead and flip to the next slide just to serve as background. Thank you so much to PCC for having this conversation and for involving City Block. To be honest, very excited to be sharing a bit about our model, a bit about really our history. Founded back in 2017, we really were purposeful about the type of transformation that we wanted to take on. And that was more so about the audience that we wanted to reach and that we wanted to serve. Purposefully looking at marginalized communities, Black and Brown populations in urban centers, and to really honestly seek out those solutions that the traditional healthcare system really has not been providing, particularly with a focus on this population. So our innovation is really the combination of who we're serving, and then of course how we're able to do that given just the historical marginalization of who we're seeking to reach. We're an integrated primary care, behavioral health, and social care practice. And of course, specifically around social care, we do actually consider that part of our clinical services, and not just about screening and assessment for social determinants of health, but how are we actually addressing those drivers of health outcomes, of member experience on top of that, and how can we really make sure that we're looking at a broader definition of success, which includes well-being for our members. We do this through a couple of key tenets within our care model. First and foremost, we consider ourselves multimodality as opposed to what other digital health companies are focused on, which is typically more the virtual first concept. We instead believe for our population, we need to be multimodality instead of focusing them and almost forcing them into a single option to get introduced to us as a model. There are times when we will have boots on the ground, knocking on their door, visiting them at home. So again, as Anne actually described, we provide virtual service, home-based services. Some of our success is actually on a park bench in some of our markets. We will meet our members where they are in every sort of way. We do this through connecting and engaging with them in order to earn their trust first and foremost, without the assumption that they are going to join our services because we are the medical provider, but instead that we are here to serve them and to help them along their journey. We are data-driven, we are technology-enabled, including some proprietary software that we have in-house that is really meant to help us look at our members from a longitudinal basis as opposed to the encounter-based systems that many of us are familiar with. And really our care model is focused on continuity, longitudinal care, but also providing those services that will avoid the unnecessary costs. So we do have a ED diversion program. We do focus on transitions of care to really think about readmission reduction. And even our mobile van that we actually have here in DC, where I'm located, is to assure that we can actually have those in-person services with full examination room in the community. And actually, we usually position it adjacent to a food bank distribution. With that, I really want to applaud the conversation and actually just acknowledge the growth that we've had over the past couple of years, and how our staff is truly the strength there, because we are clearly pulling people from across the country. But right now in 6 markets, we're in Massachusetts, New York, DC, North Carolina, Ohio, and Indiana, and potentially coming to another state near you. There's plenty of conversation about further growth. So thanks so much, Anne. I'll pass it on.
Sure. Thank you, Cameron. Catherine.
Similarly, feeling really grateful to be here, and thank you for the PCC for hosting this conversation, all of you who are logging on, and inspired by my friend and my colleague Cameron and the work that they're doing. So I think, you know, as Anne introduced me, just to kind of give a little bit of framework of where I am. So Boston Medical Center, where I've actually been unbelievably for almost 18 years, seeing patients and wearing lots of different leadership hats, and really thinking about this from the viewpoint and the vantage point of both being a practicing provider who's sort of getting to watch all of the particularities of what's happening in the ACO play out in the patient interactions, and also with the hat on of leadership and sort of how do we translate all of that into policy. So just to give people a little bit of a history of what's happened with the ACO in Massachusetts, I think there were some readings that went out. I feel very lucky to be in a state like Massachusetts. Even though we are, and maybe because we are the largest safety net hospital for all of New England, Massachusetts has really put a lot of trust in us to be sort of testing out this ACO model. So there was some initial piloting of ACOs that happened between 2016 and 2018 in Massachusetts. In 2018, Mass Health said, let's go for it. We're all in. Let's do this Mass Health ACO. And we know what happened in 2020, but we got a lot of really good data between 2018 and 2020, and now we're sort of back to how do we continue to reinvent what we're doing. As far as the primary care part of it, so for those of you who have been following Massachusetts or sort of thinking about this stuff, we have something, we actually had $1.8 billion invested from Massachusetts in this waiver. So to really say, how do we actually do care differently? Because any of you who have joined are going to understand that this is going to take an enormous jump start. It's not necessarily in the billions, depending where you are, but that's what we need to do for Mass Health ACO. Happily, that CMS actually just approved the 1115 waiver in the fall of this year to be going for another 5 years. And one of those pieces of the waiver was specifically looking at primary care capitation. So I apologize for the small font on this. Actually, somebody was joking before saying it's Mass Health, what do you expect? But really thinking about what are the 3 buckets that we're working for in terms of how ACO is going to be delivered here. And thinking about the payment reform, how that comes to practices, and then obviously how that improves patient health outcomes. I might argue if I were to make this slide, I would start at the patient outcomes and do the arrow in the other way. But obviously, those two are synergistic. And so payment in terms of primary care, which I'm very happy to go into more at another time. And that's what we're seeing as practices is changing. And particularly through what's called a tiered system. So there are 3 tiers, and those who are signing up for the most kind of comprehensive value-based care are going to get the most per member per month payments. And then obviously that's going to fund the way that they can deliver care, and really thinking about behavioral health, similar to Cameron, behavioral health integration support for that, really meeting people where they're at, not just saying you have to come to brick and mortar hospital to get your care, doing more delivery in homes, obviously reducing emergency room visits and all of those things, which of course will then lead to improved population health outcomes. And very briefly, just the next slide, just to give you an overview. Next slide. So this is only to say that if you take a look, so pre-2018, we can see that it was all fee for service, and we kind of are marching out into, you go to the last bracket and you're looking at 2023 plus, we're actually seeing there's high total cost of care risk and incentives. So in other words, more and more of our practices and more of the payers, which is part of what we're here to talk about, are joining in on this total cost of care risk. And as a result, somebody like BMC, we're getting value-based care teams to do a lot of the infrastructure and support around this work, which we're starting to slowly see trickle down to the front lines, but I know that's a longer conversation. So thank you.
Thanks so much, Catherine. Over to you, Bill.
Thank you, Anne. It's a pleasure to be here with this esteemed panel, and I appreciate the introduction, and particularly that you highlighted CCPN. CCPN is the acronym for Community Care Physician Network, and this is where the action is right now in this sphere all across the state of North Carolina. In the transition to managed care for the Medicaid population, the Academy of Family Practice, the North Carolina Pediatric Society, the FQHCs came to CCNC and said, we need to figure out a way to support the independent providers in predominantly rural North Carolina as we move into this new model of care for our Medicaid population. And building on the already existing network of pediatric, well, of all primary care practices associated with CCNC, we collectively came together as a CIN, and through that vehicle have been able to begin to move the practices with appropriate support in a very positive direction. This is a busy slide. I really had them fix this so it would be referenced. You can see from the map that we're, I think at one point we were in every county. I don't want to, and we have 100. So it is an extensive network and built on the old CCNC care management network. And next slide. Lists the many ways that we are supporting the practices, and we can talk about those at a later time. And a new wrinkle, which I think is critically important, is the formation of the Center for Community Care, community-based primary care. And because there's the realization that the workforce needs attention, and we have to be able to clinically innovate if we're going to advance these issues, and also the importance of advocating for diversity and equity and access for all to these services that are being provided by the state. So I look forward to addressing some of these as we move forward, and I'll turn it back to you, Anne.
Thanks so much. And Edward, if you can take down the slide, that'd be great. Super, thank you. So as you can see from the brief synopsis that each of our presenters provided, they are in very different environments, and their arrangements are quite distinct. I think I also want to recognize that they are exemplars and exceptions. What we know about the overall primary care landscape is that fewer than 10% are in any kind of capitated arrangement. That is a data point that was on the primary care scorecard that was issued by Milbank Memorial Fund last week or 2 weeks ago. So these are exceptional practices, and we can learn from them. I think you, in your remarks, kind of explained what motivated you to seek these new payment arrangements, but maybe you could describe a little bit more about what you need to pay attention to from a safety net perspective when you're having conversations with a Medicaid managed care plan, or when you're thinking about setting up a CIN, or when you're contemplating, developing something from the ground up, is what happened at City Block. So why don't we reverse the order, and again, from the perspective of safety net providers and patients that are more vulnerable, what particular things do you need to consider when you're moving into these new kind of value-based arrangements? Starting with you, Bill.
Well, Anne, the motivation question is easy in North Carolina because the General Assembly passed a law and said we had to do it. That we had to move from our old model, which was working quite well and had been nationally recognized, but they wanted to move to a managed care insurance product. And so to do that, it was going to take a different approach from CCNC if we were going to remain part of the solution. And so by forming the clinically integrated network, we then had the ability to approach the department, as well as the all 5 of the prepaid health plans, insurance companies that were granted contracts by the state, as a collective group. Our goals were simple. We wanted the practices who were going to participate to have the best opportunity possible to remain financially viable and continue to do the work. We knew that from the run up to this that we were moving from a single payer for our Medicaid program to now 5 payers and all the administrative burden that comes with that. And so the state did their very best. We were at that point under the leadership of Dr. Mandy Cohen, who had come to the state from CMS, and she listened, and she allowed, we maintained a common credentialing mechanism. We maintained a common preferred drug list. They continued the fairly narrow prior authorization treatments and procedures that were required. So they made the effort to help us not have extra burden, right? There is still burden, and it is still an issue, particularly for the small, and the majority of our practices are small, you know, 1 provider and a mid-level. The bulk of them are 3 providers or less of that 900 plus practices, and they don't have the ability to do that. And so what CCPN has done is build out the infrastructure that allows us to support them where they are with what they need, to the extent that we're able to do that. The insurance plans have worked hard to be responsive to our needs. Again, they're big insurance companies with layers of bureaucracy, and it's still been a challenge, but I think it was not the disaster that we were fearing. And it has, as an outgrowth, created a very robust clinically integrated network, now in its 2nd year of operation, where we're beginning to understand kind of where we are, where we need to go, and we're even looking beyond that. So it's an exciting time. I think that there are a lot of great things on the horizon, and so I'm excited to share more as the conversation progresses.
Thank you. It could not have been easy to make that transition, as we're also in the middle of the pandemic, so congratulations. Cameron, would you like to weigh in on this motivation question, and also what do you need to pay particular attention to given the population you serve and the kind of
the motivation question I minimally addressed earlier, but I think for us, we truly recognized the need, again, to respond to specific communities. And so having an entire focus on low-income populations really allows us to focus. I mean, that's one question I'd love to hear from William and Catherine, just kind of the difficulty of managing multiple populations, let alone managing multiple contracts. William, we're right there with you, and that is difficult. But of managing multiple even government programs, let alone the diversity within the commercial space, I would assume has some significant difficulty. And so for us, really being able to fine tune our care model to a specific focus on low income communities, I think assists. I think in that we are recognizing that we need to be a partner to safety net institutions, not just the hospitals, the emergency departments, the specialty clinics that are serving our members as well, but also the primary care practices. We are not necessarily the attributed PCP across the board for our population. So in recognizing the importance, the stability that FQHCs provide in the communities where they are currently, and there's nowhere near enough, I'll say that as a former FQHC leader. You know, we in City Block really do want to wrap our services around both the member as well as the FQHC and really provide those supplemental services. So I think part of really our focus has been to determine where the need is most and to be laser focused on providing those services, whether it's in the social care space, particularly again in urban settings. The housing situation, the inventory, the program availability is difficult. Whether it's focused on the cultural competency of our workforce and really more the cultural humility that we need to serve in order to earn the trust of our members that are seeking out services, how we actually partner with them in their care and advocate for them no matter where they're receiving services, not just within our own care teams. I really think when we're thinking about supporting the safety net institutions, because our goal is not in any way to replace them, but in supporting them, we need to identify what their needs are and then fill those gaps. I truly see our care model as being able to fill those gaps as opposed to replace, because that's truly where the transformation needs to occur, that we tend to continue to see members of marginalized communities dropping through the cracks. So how can we actually support the services that are already being supplied and fill in those gaps? And that's really where I'm proud that the City Block care model is able to fit in. Lastly, I'll say, my experience at VA, everybody always asks me my transition from probably one of the largest bureaucracies to this very different world. For me, the clinical model is awfully similar. I would definitely tout that VA is one of the earliest concepts of obviously whole person care, and if you hadn't seen that NAM report that just came out in the last month, I would highly recommend that. I want to implement that in every sort of way through City Block's care model, but it's also I would say a concept of value-based care that VA probably doesn't tout as much as it should, but just the fact that they have that level of accountability, of empanelment, and responsibility for their members. So there is no concept, it was drilled into all of our heads, there is no concept of leaving any man or woman behind. And that's what these systems need. That's where, again, the gaps need to be filled in. And VA does that with such strength. It's not perfect, but I would say it has some benefits for veterans that are above and beyond what the private sector has been able to really figure out. And I would argue that the value-based systems that all three of our organizations provide is getting closer. It's a step closer because we have that accountability, we have that responsibility, and we're proactive in that sense, as opposed to the rest of the system that clearly is just focused on disease-based conditions and acute response.
Yeah, thank you so much. Accountability, flexibility, and I also think creativity. I mean, everything that you all have said is, really, I think, demonstrates tremendous creativity to meet the need, and a different payment model kind of frees you up to think about other ways to deliver care, whether it's different modalities, going into the home, whatever it is. Catherine.
Yeah, I would just echo so much of what my co-panelists have said. I do think that, first of all, similar to Bill, we had a mandate from Massachusetts, but all of us, in safety net hospitals have been so eager to be part of an ACO, in part because the real focus has been how do we pay for equity and how do we pay practices to show that they are actually making a difference and recognizing, the system of racism in our the way that we deliver care and actively addressing and engaging that. So that's been so refreshing to have that on the payer side. I will say that you know, if I were in a place where we were just starting to build this now, right? So this has been a slow moving experiment, but I think one of the pieces is, how do you know what you want to aim towards, right? So what are the quality pieces that you're actually looking to improve? So we know that, you know, we want quality metrics in terms of patients' outcomes, but we also really want to be looking at things like access and equity and integration and care-based teams, and how are you going to build those? So PCC and other places have done tremendous amount of research and publication on those metrics and what actually changes the outcomes for patients and frankly for providers and for communities. So really kind of being clear about what those metrics are. And then when you're thinking about payment, I think it's really easy. You know, actually you brought up a really important point, Cameron. So you have all these different payers and you get them in the room, and how are you going to do that? So first of all, you need a quarterback, right? So we actually now have a value-based care team that manages all the different payers and sort of holds the different payers accountable. So it's not just each practice having to do that. So I think if you're going to be entering those kind of contracts, it's really important to have a, you know, to continue the sports analogy, a quarterback, or I played rugby in college, so an 8-man, you know, holding the scrum and thinking through those pieces. And then to your point too, Cameron, I think this piece around trust is critical, right? So we're all trying to do something really different. So how do we make, not just continue to replicate these systems of oppression and lack of transparency, and how do we actually get folks from community in the room at the table making decisions about what's actually going to impact care. And I think those are really critical pieces. And then whatever kind of data you're gathering, you feed it back to the community, and the community gives you their data too. So it really is kind of full transparency of data sharing. You know, and one of my friends said, change moves at the speed of trust. And I think that's definitely true for what we're doing on the ACO side. And so, you know, keeping all of those pieces in mind. And the last thing I would say is not being discouraged when what is on the outside looks different from what's in the inside, right? So I shared that we're now in these kind of value-based agreements. And yet, if you go and talk to my providers on the front lines, they're going to be like, I'm still fee for service. I don't know what you're talking about. So we're starting to see it, but like, what's under the trunk may not feel the same as what all the kind of leaders and value-based folks are saying. So how do we make sure the outside and the inside start to feel much more congruent? So that is a matter of time and leadership and advocacy. And that's certainly happening on our end, but it's slow going. So just not to lose hope on that.
Thank you so much. Now I'd love to get the panelists talking to each other. I mean, I heard a number of common themes across all of your remarks. One is the importance of accountability and what are the metrics, and getting to the right metrics that really speak to the clinicians and get the kind of outcomes that we all desire. That was one theme. I heard the importance of partnerships and relationships, whether it's, you know, with community-based organizations or relationships across the various health plans that you're working with, or if it's with the practice and patients. Relationships is really critical. A component of that is trust. And when you're working in communities that have been subject to less than ideal situations and structural racism and other challenges, the trust may not be there. And so how do you rebuild that? So those are some of the themes I've heard. Now I really want to open it up and give you all an opportunity to be in conversation and perhaps ask one of your colleagues about a point that they made.
William, did you have one? Go ahead.
Well,
Yeah.
I was going to say, with regard to we learned some amazing lessons. We had the opportunity to help the state at the beginning of the pandemic we had the infrastructure at CCNC, so we were able to put together very rapidly community contact tracers. And we worked intentionally very hard to make sure that we hired a population of qualified tracers who mirrored the populations around the state that they would be working with. And in doing so, found that it was much more successful than we might have imagined. And so that was one good lesson learned, and an opportunity to do that now in other areas. We also have long understood that care management services provided by care managers who are from the communities that they are serving do far better than a care manager calling from Chicago to North Carolina and making sure that so-and-so's got their medicine and did they get their appointment. And when the care manager speaks your local dialect and knows which churches in your community have food banks that you can go to, you can serve that population in a much more effective way.
Yeah, hands down, that's a very large part of the success of our engagement efforts. Our community health partners, as we call them, not just workers, but community health partners, are hired directly from the communities where our members are located, and we actually elevate them to be the main point of contact for the care team. We're not physician or provider focused in any sort of way. Through our case conferences where we're really talking about kind of population health management, we involve the community health partners, and then they are the ones connecting with the members, knocking on the doors, and answering their questions, updating care plans when, of course, they're able to. A lot of times it's the RNs or the physicians doing that, but I think our CHPs, as we call them for short, are a clear necessity to how we're able to not only communicate, but then be successful in our care planning and our goal reaching. Because I think one of the true difficulties we found up front, it's easy to act as if you're accountable if you're just have the names on a list, names of members on a list, and maybe a single primary care visit for the year, right? And we know that that's not even feasible in the full value-based system, but I think our ability to have that connection to relate with our members beyond when they need healthcare. And I think that's going back again to that whole person care model that's necessary for this to work. From a member standpoint, they see us as more than just their healthcare provider. And I think that's the level of engagement that we need for this to continue to be successful.
Yeah, and I would just add, because I think, my question around it, or my kind of thinking around it, and similarly at BMC, we call them community wellness advocates, right? So it's sort of very much the same, very much the same aspiration, but not always done perfectly, right? Because it's a huge system. And one of the pieces that we're really working on is, with our social determinant of health screening and looking at unemployment, actually we're piloting having people who are interested go through a training program to actually be hired by the hospital. So it's like, how do we actually continue to hire folks from the community to be delivering care also as part of that model? But I think to your point, Cameron, and one of the questions that I have thought a lot about is, it's not enough just to have it on the primary care capitation list to say, okay, you need to have community health workers or whatever, however you want to phrase it. But what does that mean? Who are they? How are you training them? How do you keep accountability to the community as you're doing this work? And I hope that that's the next level of metrics, but I don't want us to fall asleep at the wheel around those things, and recognize that just because it's written down doesn't mean it's going to be done well. So how do we hold each other's feet to the fire around that work?
Well, those were all, I mean, you each provided incredible examples of how you've implemented, you know, a way to reach the community by being very thoughtful about who you hire, how you train, how you bring them in, the relationships that they're building so that you can be successful in, you know, helping people to restore themselves to health or managing their condition. It's not just like, did you check the box? I mean, this is about a relationship over time and a lot of different subtle inputs. It doesn't happen, you know, in a couple of months. It really is the long game, and you're going to see the benefits over the long game. And yet, payers, the government, can be impatient about how do we get there quickly.
And Anne, I'll piggyback on that. I think one of the difficulties, and I'd love to hear any solutions because we're trying to work on this as well too. The redeterminations, the attrition, the changing of plans for individual members when so much is based on that continuity, the longitudinal relationship. But yet we know that there is this just ongoing threat, particularly one coming up quite soon. And we are really mapping out per state, because of course for us every single state has a different plan of how they're looking at those redeterminations post public health emergency. But to me that would be a significant policy change that we need to you know, advocate for as a group, just really thinking about the needs for this population to address the inequities, to address the access issues. How do we get away from this annual redetermination piece so that there aren't individuals again lost to follow up, so that we can, you know, maintain those relationships and really think about the longitudinal outcomes as opposed to just achievements in a single year. I'd love to hear if you guys have solutions. We're trying things piecemeal right now, but I think that's one of the difficulties, the attrition of this population.
Bill, looks like you want to jump in here. Go right ahead.
It'll slightly change the subject, but the concept of attrition is important. It seems in North Carolina like we got more patients than we know what to do with, but we don't have enough doctors, and so since we're looking at a statewide operation, we are, you know, we're being forced to focus as intently on the health and well-being of our practices as we are our patients, because that's got to be there. And so CCPN, we have practice representatives, we call them PRRs, and they have a small stable of practices, and they make frequent contacts, monthly meetings. We've done it primarily by Zoom, but we're getting ready to go back in the field. And practices need help with their electronic health record. They need help with being able to effectively transmit the data necessary to do the accountable care work. And we looking at quality and how they create a workflow that minimizes disruption but allows them to approach the quality, care management, pharmacy, behavioral health. So we have content experts in all of these areas regionalized throughout the state that are essentially making prescriptive prescriptions or descriptive prescriptions for these practices to help them always be slowly moving to being a better practice in the midst of seeing this population. And so it really is not unlike having a complicated patient who has no transportation and a minimal number of family members that can help them, and you are putting a plan of care around them to help them deal with that. In North Carolina, where CCBN is trying to support and help our practices in a similar way. And it's difficult to run an effective, viable business in medicine in a rural part of the country. And that has to be at the forefront of any policy discussion, at any level. And I just hope that folks will hear that and look for ways, to improve that as well. North Carolina's it's a big place, and we have thousands of providers and lots of patients. So it is a critically important thing.
Thank you, Bill. And I can see where the CIN really helps to support the practices. And on the other side, these redeterminations are going to cause all this disruption for the patients. And we know how critical it is to have that continuous relationship around trust, around, following, continued success in whatever treatment modalities people are on. Just the continuous relationship is really, really critical. So what tips or what are we learning from other states as they anticipate their redeterminations? I'm back to Cameron's question for a moment. Is there a way that you're getting all of your 6 states together to share best practices? Are there forums where these conversations are taking place to try to figure out how to mitigate against some of the worst effects of redeterminations?
I think that's a great idea. I think you all should host a best practices idea session around that redetermination. I mean, I will say that for us, it's just really boots on the ground, having tons and tons of support for our patients. April 1st, all this is coming down the pike super, super quickly. And, a lot of our patients find out they're not part of a plan anymore when they go to the pharmacy to pick up their meds. It's sort of this point of care disaster, or they come to see us or something. So, and I really think about, again, all of what we spoke about is how do you have care teams out in communities? How do you set up locus of health and wellness in communities? So you can get people coming in to, we learned a ton around telehealth. Can you have people coming into local libraries and community centers to be signing back up? How do we do kind of shoulder to shoulder support en masse? I think is really one of the things that we need to be thinking about. And we know kind of how to roll, we know how to quickly roll things out. We've proven this. And this is despite it not being a virus, it is critical to people's health that they remain with the providers that they know and they trust for their outcomes or their health outcomes. So I think there are ways we can think about it, but probably, unfortunately, I think we tend to be pretty short-sighted on planning things before that you have to, put out a fire. So the more that we can put our brains together, I think is a great idea.
Yeah, well, I must say that I think primary care was one of the most responsive parts of the health system when COVID hit, and it wasn't always, in the papers, but just saw how primary care figured out how to deliver care in the parking lot and all kinds of ways to reach their patients, and at the time didn't know if there was going to be remuneration. So hats off to the professionalism of primary care during a very difficult time these last number of years. I'm now looking at questions coming through in the chat. We've got a couple of minutes to answer some of them. I did bring the question up about one posed to Cameron about are you getting your 6 states together. Another is just the role of public policy. In 2 instances, the Medicaid at the state level made a change, and that precipitated, some changes downstream. What, if you could wave your magic wand, would you ask either state Medicaid directors or at the federal level to do to really strengthen care for the safety net and strengthen safety net practices? What would you guys have on the top of your list?
Well, I'll start just with 2 items from a very long wish list, but I think one of them that a lot of us are working on is at least doubling investment in primary care, right? So just like we all know the data so clearly in terms of primary care being the only specialty that will improve health outcomes and lower costs. So that piece, and then something that I think Bill alluded to really quickly, but I think would be amazing on a federal level, is actually having all of the same metrics with transparency, easy to get data, so that people could be following the same playbook and lessons could be shared more easily. Just even from today, you can see how 3 different people are doing things with some congruity, but also with a lot of differences. So we could get a lot further together than trying to figure this all out, independently. So that would be two of my wishes.
I echo that. One of my partners who understands all the payment stuff much better than I do says that the amount of money that the country spends on pediatric primary care is budget dust. And if you tripled it, nobody would notice. And yet we are preventing kids just simply through the immunization process of untold numbers of terrible diseases that can kill them. I've been practicing long enough. The first decade of my practice was pre all of the amazing vaccines we have. And in our practice, in our little rural county in North Carolina, we in our practice would lose anywhere from 2 to 5 children a year. They would die from these now preventable illnesses. So that should be enough evidence to dramatically increase. The other thing that I would ask is finally, because they've talked about it, but they've never done it, make behavioral health services paid on parity with physical health services. And we have a fully integrated mental health team in our practice. We have child psychiatrists, we have PhD psychologists, we have multiple therapists with different skill sets. We cannot meet demand. And we as partners underwrite that sum. And my partners are committed so far to doing the right thing, but we are just not there yet as a society who is talking the right talk, but have yet to figure out how to influence the policymakers and the payers to really pay for what we know is important. I mean, it would be life-saving and life-changing for all ages and all populations.
Well, music to our ears. I think there's a lot of nods around our virtual table, and I can imagine in the 300 plus folks that have joined here today that we should really think of mental health in the same way we think about physical health and really integrate it. Thank you so much for your remarks. It was a delight to be in conversation with you all today. You're doing amazing work, and we so appreciate it. And then if you can throw up the slide for those of you who are members, we're going to go to a more in-depth conversation, and thank you again for joining us here today. And here's some resources at the PCC. Have a wonderful afternoon.
Thank you.